This one particular photograph here shows something over 24 feet from a simple sneeze.
Hello, I'm Faith Rogers, host of today's program, COVID-19 Keeping Up with a Moving Target. This is a September 23rd update of DKB Med Radio's Coronavirus Educational Series. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC and AAPA credit, as well as AMA PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. There you will also find all of our previous COVID-19 programs and have access to other free CE programs on a wide range of topics. The slides for today's webinar can be found in the resource list window. Today's learning objectives are: discuss the current trends in COVID-19 testing, and describe the current knowledge of transmission risk in schools and airplanes. This activity is supported by an educational grant from Pfizer Incorporated and in kind by DKB Med. All activity content and materials have been developed solely by the activity directors, planning committee members, and faculty presenters. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. Dr. Auwaerter, thank you for your time today.
Thank you, Faith. This late September presentation marks some somber news. As many know, more than 200,000 people in the United States have lost their lives to COVID, perhaps more. And worldwide, it remains a global pandemic. In the United States, over 40,000 cases on average are diagnosed daily, and still more than 800 deaths every day due to this coronavirus. I want to focus a little bit on transmission and epidemiology because it's again very prominent in the news for a variety of factors. But in the United States, gratifyingly, the percent of positive tests has trended downward despite increased testing. So that's good news, but we still have large numbers of people who are positive every day. And where that's occurring is different. It seems to be a moving target, and states that are very prominent now include states such as Minnesota, Montana, Oklahoma, Wyoming, and Utah, who have had peak 7-day averages compared to earlier this summer. And many of these places have not yet seen dramatic numbers like many states did earlier in the pandemic. Looking a bit differently, where you're looking at the number of cases over a week, you sort of get a map where much of the Midwest, Texas, and the South Central states and Northern Florida are quite prominent compared to other parts of the country. So I think as we're moving into the fall, we've opened some schools, universities are starting to attend, but people, I have a feeling, are letting down their guard. College football is playing, the NFL, people are getting together, not so much in stadiums, but perhaps together and watching on the television. And of course, everyone would love to have life return to normal, but this letting down the guard, I think, bodes poorly. And already in the news, France and UK have seen a big upswing following the summer holidays. And of course, the concern is that the current declining trends might reverse, but we're also starting at a far higher level than the countries in Europe. So I think this is quite important and speaks to some transmission issues, which I would just like to emphasize again. Certainly, many people are aware of the 6-foot rule, which was based on respiratory droplets. But I think there's enough evidence now that suggests, especially For people that are singing, uncovered sneezes, you see people that are able to project respiratory droplets far further and perhaps in smaller size that could remain suspended, especially in rooms where there is not good air circulation and so on. This one particular photograph here shows something over 24 feet from a simple sneeze. So, as I've already mentioned, colleges returning, there have been many cases on college campuses and schools, which I think are trying to handle issues with mitigation techniques on the campuses. Some have been successful, others less so. And luckily, this is a population at lower risk for severe disease, but whether they will be the nidus for spread to the communities remains. This would be also true if you look at elementary schools and even secondary schools. We know for influenza, children are the main drivers of infecting seniors. And indeed, the best way to prevent seniors from getting ill are to immunize children, just because vaccines don't work as well for the flu in older adults. People may say, well, gosh, the children don't get ill, and perhaps the teachers and supervisors are wearing good masks, they won't get ill. But this was a recent news from Utah, which looked at a daycare center and found that 12 children in the daycare center, including 3 who had no symptoms whatsoever, subsequently infected 12 people outside, resulting in 1 hospitalization. So as many people are struggling with trying to return to work or trying to supervise children and are going back now with daycare issues, I think this again remains something that is not risk-free. There may be mitigations, but this is just part of the issue that I think anyone that is at high risk for severe disease needs to remain very cautious as we move into the respiratory season. One of the more frequently asked questions to me are about travel risks. And the CDC came out with something that said, look, they tried to contact trace, although incompletely, over 1,600 people and could not find a documented case of transmission. And of course, just looking at airline professionals at work, such as pilots or cabin attendants, there doesn't seem to be dramatic numbers of people that are infected. And of course, the air circulation in planes is actually much better, for example, than in some closed restaurants and so on. Now, there are a number of examples on the right-hand side of this screen where there have been more careful investigations where it does appear that one person who was infected others on long flights, and that long flights, especially those overseas, may be at highest risk. There's one example that I thought was instructive that we could go through, which is in a recent emerging infectious disease case. And basically, flying risks have not been well described, but this was an evacuation flight from northern Italy to South Korea in late March, almost 300 passengers on an 11-hour flight, and everyone was quarantined for 14 days and followed. Now, importantly, everyone's wearing an N95 mask. This is an important distinction and not what's really going on right now, where most people are wearing cloth or surgical masks. Everyone apparently socially distant before pre-boarding, but the flight was full. And if you look at the flight here, when they arrived, everybody was tested a day after arrival and again 2 weeks later, essentially. And what they found was that people that were asymptomatically infected and found to be positive, here in the red on the second floor or first floor of this plane, one person developed symptoms, but the one person that developed symptoms was over a week later, which is reasonable timing to suggest they were exposed. The only common link they could find was an airline restroom, because it's the only time where people probably removed masks while they were in the restroom. Whether that was from air or from a hard surface transmission is unclear, but there was only one transmission in this particular plane, which speaks at least to the fact that it is not a widespread infections that it can occur, but it's still quite possible even when trying to wear N95 masks as much as possible. Now, the Diamond Princess cruise ship was an example that's taught us a fair amount about transmission, albeit fact, this is obviously in more confined quarters and very early in the epidemic. People were not paying attention or not following infection control issues, perhaps as well as they ought to. And over 20% of the staff and crew became infected. The case fatality rate was nearly 2%. But importantly, a vast majority of people were not symptomatic initially when they were evaluated. And the thought is that asymptomatic transmissions account for most here. So what this really translates to is that many people who are not infectious early on, but positive for the virus, here, the higher the number, the more likely people have high amounts of virus. And this is before people are known to essentially be infectious or have symptoms at day 0. So this can even go back potentially to 4 days, but certainly by day 2, many people are highly infectious and remain so for the first 4 to 5 days before it declines. This red line is typically where people, when it falls below, even though we can find the virus, they're no longer infectious. And the other factor is some people are much more capable of spreading this. The estimates are that about 10 to 20% of people contribute to 80% of cases, and these are the so-called super spreaders. These events are at least contained enough so we can understand if they're outbreaks, such as weddings or on ships or campsites. But in day-to-day communities, we don't really know who the super spreaders are and or the situations, and it's probably more sporadic, but it does speak to the sense that probably people that are in this phase here a few days before and a day or two after infection may be the ones, especially since they don't know they're ill, if they never develops infection, can transmit the virus. Now, in households, a number of studies I thought were worth reviewing, and on average, this is fairly similar, interestingly, to influenza, which may have an attack rate in a household of somewhere in the low teens. And it's somewhat higher, of course, with your bed partner, lower for other members, and is variable. But it gives you an idea that not everybody in a household would acquire it. But again, if you have super spreader events, everyone's sitting around a table playing cards, that's going to be quite different than everyone sort of doing their own things at different times, and a family that doesn't eat dinner together, for example. So the key point here is to wear masks, especially for people at risk, and social distancing in households during this respiratory season, because given this asymptomatic condition and the fact that often younger people are just not going to be quite as consistent with not engaging in social interactions, and social distancing and mask wear would be prudent to protect themselves moving into this. And of course, masks have always been an issue, and obviously it's not something that's very comfortable, but I think because of the confusing information, I would just emphasize that I think you could ask almost every doctor in the medical community that at the moment, masks are the most important thing we can do in maintaining our distance to help protect ourselves and others from the coronavirus. Now, I'd like to close by just updating on what I call the vaccine race. And this is tracking somewhat with also the presidential election in the United States, as you know. By the WHO, there are over 300 vaccine candidates, and the phase 3 trials, the ones that will prove efficacy and safety to a large degree, there are now 10 candidates, and I've listed them to the right for you, with the latest entrants being Johnson & Johnson. In full disclosure, I own stock in this, but they have just started a United States trial, and it is really the first US entry with this particular adenovirus-based vaccine into the market. Now, importantly, as you look at this, when are we going to know results? Now, initially, the German and Pfizer initiative using an mRNA-based vaccine said October. Realistically, it looks like this is probably more November or December. Moderna is slower and probably will be behind that. And the important point I'd like to make is most of the vaccines are 2 injection strategies, which mean that you need really 3 months after your first vaccine to really get high quality immune responses. Only two, the J&J and the CanSino Bio ones, are single jabs. So this is something that has to factor in, which is why there is a lot of uproar about saying whether vaccines would be available and people would be protected. And it is not terribly likely that, although we may have phase 3 results by this late fall or early winter, it's going to be at least 6 months till the logistics of vaccine rollout, as well as the full results of the phase 3 trials, really will influence our behaviors, I hope, in the United States. Lastly, the vaccine portfolio here I have from the Financial Times, which recently put together this graphic, which I thought was useful, that really looks at what each country has done. And interestingly, of course, the wealthier countries have a large vaccine portfolio where they are getting enough doses of all the vaccines to perhaps have each person in their country get anywhere from 3 to 5 of the vaccines. Of course, we're not sure all these will work out, but you can get the idea that this is the basis behind Operation Warp Speed, that you're going to have 100 million plus doses of the vaccine, whether we know they're working or not. And I do applaud these kind of manufacturing efforts. The UK actually is even a bit better put together in terms of the number of vaccines for each of their citizens. But you can see this is a strategy that many countries are following, but unfortunately lower resourced countries will not have this kind of availability unless the United States or other initiatives really come under way that can help. And I think it is important to try to distribute the vaccine as widely as possible, both of course for human issues, but also for the benefits that global health would lead to general security and stability. So Faith, do we have a question or two for today?
Yes, we do. Our first question is, can you comment on the CDC report that showed that people who had positive COVID tests were twice more likely to have eaten at restaurants within 2 weeks as people who did not? The survey didn't distinguish between outdoor dining and indoor dining. Do you think that outdoor dining carries significant risk of COVID transmission?
Right. So there are a number of aspects here, but simply if you think about it, when you're having dinner, you're across from somebody or they're to your side for usually 2 to 3 hours. They're unmasked and you're eating and speaking at the same time. And we know that there's more generation of droplets in that time frame. And if you're indoors, depending on the particular restaurant, the ventilation is not going to be nearly what it is outdoors. We do know from studies early on in China that perhaps less than 1%, I think it was 0.6% of people appeared to acquire COVID from outdoor settings. I do think that the vast ventilation outdoors is a dilution factor. So unless if you're very close to someone else, that there's significantly less risk. And so far, I don't think I've seen a single outdoor dining exposure leading to outbreak and transmission compared to indoor. So again, I think especially for people at high risk, I mean, I feel terrible for restaurants who are in such bad straits, but indoor dining this fall will be fraught with issues for anyone who is older or has significant health problems.
Okay, and our final question this week, is there an association between COVID-19 illness and new onset type 1 diabetes in children?
I don't think there's a strong association, but type 1 diabetes is an autoimmune disease where islet cells are unfortunately destroyed by the body's own immune responses. We know that it can occur as a post-viral illness. I am not at all surprised that a virus like the coronavirus could be implicated in some. Of course, the virus is so common, it may just be a statistical association. So I think as we gain more experience, it's going to be issues that we'll really have to try to tease out if there's true causation.
Great. Thank you again, Dr. Auwaerter. If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. Any questions or issues, feel free to email us at the address listed. To submit questions, please send them to qa@dkbmed.com. That's Q as in question, A as in answer at dkbmed.com. Again, thanks for joining us and thank you for your dedication to your patients with COVID-19. Thank you again for your time, Dr. Auwaerter.
Thank you, Faith, and thanks so much for listening. And please, everyone, stay safe, and we'll talk again soon.